In this video, I will be going over reliability and validity of diagnosis and issues faced regarding the two. So far, we've looked at classification systems as systems or diagnostic systems that adopt a symptoms approach, wherein through research, categories of disorders have been put in place, okay, and each category has disorders with specific symptoms and rules listed that basically support clinicians diagnose a disorder. For example, in the DSM, mood disorders are a category of disorders, and within this category, there are several disorders, including major depressive disorder, bipolar disorder, postpartum depression, seasonal affective disorder, and so on. And each of these disorders have specific symptoms and rules in order to establish a diagnosis for a client or a patient. Okay? The two characteristics that determine the quality of a diagnosis are its reliability and its validity. We've come across these two concepts in relation to research methodology in the past, but in the context of diagnosis, these concepts are slightly different. A diagnosis is reliable if it is consistent across clinicians, which basically means that two or more clinicians who are diagnosing the same client or patient using the same classification system should be able to arrive at the same diagnosis for that patient. Okay? So let's say Johnny, over here on the left, is reporting that he feels low most days, has no motivation to get out of bed or do anything for that case, sleeps through the week, and has lost his appetite for more than 2 weeks. Clinician A and clinician B and clinician C on the right side should arrive at the same diagnosis of major depressive disorder for him. If they don't arrive at the same diagnosis, the diagnosis is considered unreliable. Okay? Even in real life, if you ever consult a psychologist with a concern for your mental health, ensure that you get a second opinion. This is important, especially when it comes to treatments of your disorder that involve medication, as these medications or treatments tend to change the neurochemistry of our bodies. In the case of a misdiagnosis wherein there isn't, in fact, a specific disorder or there's the wrong disorder being diagnosed, this could have an adverse long term impact on your body and your neurochemistry, which could further affect your mental health. So, two or more clinicians coming to a consensus regarding diagnosis of a client is referred to as inter-rater reliability, okay? And this is achieved in two different ways. The first way, which was used in earlier research, is when a clinician conducts a clinical interview with a client, okay? And this interview is basically audio or video recorded and passed on to other clinicians, okay? The other clinicians then review the clinical interview recording, okay, and arrive at a diagnosis independently. So basically, clinician A conducts the interview, okay, and records the interview, then passes it on to clinician B and C, okay, and both of those clinicians watch the hear the audio recording or watch the video recording and try diagnosing the disorder, okay? And if they're all in consensus with one another, that shows that there is inter-rater reliability, okay? The strength of this format is that it ensures consistency. Okay, the assessment is made, or the diagnosis is made based on the same questions that clinician A asked, okay, and also the same responses and reactions of the client. So that's a strength. Nonetheless, there is something problematic about this, which is it does not reflect real life diagnosis, okay? Clinicians in real life conduct clinical interviews independently. So if you go to clinician A and then later you decide you want to get a second opinion, they're not going to use a video recording or audio recording to conduct your diagnosis. Instead, they will conduct a fresh interview with you that is independent from the first one. Okay, so there is some amount of artificiality in the way of using recordings. Um, Additionally, clinician A, who has conducted the interview and recorded it, may ask a set of questions and elicit specific responses from the client, which may be different from those of clinician B. Okay, and this is especially important because personal biases and sick role biases of clinician A may influence the way the interview was conducted. Okay, so if I have a bias against a specific gender or specific ethnic group, the way that I try diagnosing might be different. Okay, I might ask questions that are leading. So then the video or the audio recording that the next clinician receives is already biased. Okay, that is inherently going to influence the reliability of the whole diagnosis. So, all in all, the use of audio and video recordings as a method makes the establishment of reliability quite artificial. And finally, in the case of audio recordings, there's also the issue that nonverbal cues such as behavior and body language cannot be observed, okay? And that is necessary for a holistic diagnosis because not everything can be based on the self report of the client or the person that is with them, okay? In the second way, two clinicians conduct two separate and independent clinical interviews, okay, with a client or a patient. While this helps overcome the issue of artificiality and is, in fact, more representative of real life scenarios, time in this case becomes a factor that would influence the diagnosis. So, symptoms of any disorder are dynamic and change over the course its of the disorder. Okay, so the longer the interval between interview 1 and interview 2, the more challenging it becomes to determine whether the differences in diagnosis, if there are any, is a reflection of genuine change in the client and their symptoms, or whether it indicates inconsistencies or in unreliability of the diagnosis. Okay, and it's very difficult to make a difference out of the two when there is time as a factor. Okay, this way of establishing reliability then is also referred to as test retest reliability, and it is a type of inter-rater reliability. Okay. Reliability of diagnosis is quantifiable and can be expressed through the Kappa coefficient, which is basically arrived at through statistical analysis of, a group of clinicians' diagnosis. Okay, and they try to assess the degree to which each of these clinicians are in agreement with one another regarding the diagnosis of a group of clients or a group of participants. Okay, so kappa, which is the coefficient, can range from 0 to 1. 0 indicates no agreement between diagnosis, okay, and 1 indicates absolute agreement between diagnosis made by different clinicians. And you can see over here there's different ranges. So here you can see 0.21 to 0.39, it's minimal agreement. Then when you go to the higher part of the range, there's 0.8 to 0.9, which shows a strong agreement, and above 0.9, there's an almost perfect agreement between clinicians regarding a diagnosis. Moving on, validity, on the other hand, is related to the accuracy of diagnosis. In this case, the accuracy relates to the degree to which a diagnostic criteria or a system measures the behaviors or disorder that it intends on. Okay, so if it's depression that they are diagnosing, are the symptoms relevant to depression or do they indicate another disorder? Okay, validity, unlike reliability, cannot be quantified. Okay, and hence indirect measures are employed to establish the validity of of diagnosis, and these mainly focus on identifying possible biases in diagnosis that might surface during the process. If the diagnosis is influenced by factors not related to the patient's disorder, aka extraneous variables, as we see in research methodology, that diagnosis lacks validity. Okay? There are two main ways of establishing validity as well. The first is establishing systematic biases in clinical judgment. This is achieved by comparing the diagnosis of the same patients by clinicians belonging to different backgrounds. Okay, and these backgrounds can be of different things, but some common ones are of theoretical background. Okay, such as being someone who follows the cognitive behavioral therapy kind of conceptualization, or the humanistic conceptualization, or the psychodynamic conceptualization. Or these clinicians can be from different cultural backgrounds, and if they are not in agreement, that would indicate that the culture or the theoretical background of the clinician is an extraneous variable, or an extra variable, or a bias that influences the validity of the diagnosis. Okay? So, the second way is testing the ability of the clinician to identify a disorder correctly when the diagnosis is already objectively established or known. Okay, but um, they basically do not know the diagnosis, and it's disclosed to the clinician. So imagine that I was the clinician who was being tested on whether I can make a valid diagnosis. Okay, and client A came to me and had been already diagnosed by other professionals. Will I, a different clinician, be able to correctly identify um, the disorder given the symptoms that they present? Okay. This is similar to inter-rater reliability, and it is important to understand that the relationship between validity and reliability is an important one and cannot be ignored in the case of diagnosis. So, the relationship between validity and reliability is best depicted with the help of the metaphor of shooting a target. Ideally, we want to hit bullseye consistently. Hitting the bullseye suggests validity, and consistency suggests reliability. Nonetheless, this is rarely possible. If a diagnosis is reliable, it isn't necessary that it is valid. But if a diagnosis is not reliable, it cannot be valid. A reliable but invalid diagnosis is dangerous because it can cause stigmatization and the prescription or prescribing of ineffective treatment. Okay? For example, going back to Rosenhan's research, according to the pseudo patient's self reports of hearing voices and the use of the DSM 2 back then, a diagnosis of schizophrenia was established by the professionals in the hospitals. Okay, the diagnosis was reliable back then because that was the criteria. Okay, but we now know that hearing voices is not sufficient for a diagnosis of schizophrenia. Okay, so based on one symptom, we cannot diagnose schizophrenia. So that diagnosis back then was not valid as how we see schizophrenia today. Nonetheless, with that diagnosis, participants were hospitalized, would have received treatments involving medication, and also um, might experience stigmatization due to the label that they receive in their documents, even after they have left the hospitals, right? They received schizophrenia in remission. Okay, so that label of schizophrenia still remains with them and can have an impact on how they are viewed by by employers, family members, and so on. On the other hand, an unreliable but valid diagnosis is not possible, okay, and is a logical paradox because a diagnosis that is not consistent over time and across clinicians cannot be valid. It is through agreement between clinicians and over time that we are able to establish classification systems. So if there's no agreement, that basically means that diagnosis is not valid, okay? There needs to be a consensus in the field about what makes up the diagnosis of a specific disorder. which leads to the trade-off between reliability and validity, which continues to be a limitation of classification systems till date. Ideally, a valid diagnosis of a disorder would consider the multiple factors and contexts in which the disorder manifests. Okay, so basically, is the cause of the disorder biological? Is it due to genetics? Or is it because of faulty thinking patterns? Or is it because the person went through extreme trauma? So there's different reasons why a disorder might manifest. Okay. So, when the first classification systems were put in place, there was a lot of effort to describe and explain disorders through their causes. But this resulted in subjectivity and disagreement as there are different theoretical orientations, okay? And that would then influence how they viewed the cause of a disorder, okay? As a result of that, there was a shift in um, classification systems to description over causes. Okay, so this is basically a shift to symptomology over etiology. Okay, and this basically helped standardize the classification systems to have observable symptoms that all clinicians that are diagnosing can come to an agreement with. Okay, um, and again, this helped with consistency between clinicians. But in the process of moving to this kind of classification systems, validity is compromised because we are only looking at the symptoms of disorders, okay? Which is pretty superficial and surface level because there is so much more to a disorder than its symptoms. While achieving reliability of a diagnosis is a success for the field of abnormal and clinical psychology, compromising on validity has two major concerns. Okay, so first, disorders have unique presentations in individuals. So basically, there's heterogeneity of symptoms. This means that the same two people experiencing depression will have different symptoms that presents. Okay, and often there are also overlaps in symptoms between disorders that result in comorbidities in disorders. So, for example, anxiety disorders often are comorbid with depression. So, relying only on symptoms for diagnosis doesn't only inherently affect the validity, but the reliability of the diagnosis as well. What's more important is that without knowing the root causes of the disorder in the client, treatment may not be as effective. Okay, so if depression is being caused by neurobiological factors, okay, and we are giving the client treatment that is cognitive, right, then that makes the treatment ineffective or less effective for this client. Okay, so knowing the cause of the disorder is very important. So, um, when diagnosing, for example, malaria and COVID 19 that have similar flu like symptoms, we know that the root causes of these two different illnesses are different, okay? And there might be different viruses involved and different agents involved in it, okay? And hence, we're able to use or have different approaches to treatment based on the causes, okay? The same way, there could be different mental health disorders that have similar symptoms but different causes. Knowing the cause of a mental health disorder would then improve treatment, okay, and prediction of its effectiveness. So, all in all, that would improve the field of abnormal and clinical psychology. And with where we are currently, there are tests of biological markers of a disorder, and clinicians and therapists do put in significant amount of effort into understanding the context and the history of the client and their experience of this disorder before determining which treatment is best suited to them. Okay, but there still needs to be a lot more progress, and genetic markers and genetic research has been contributing to this, okay? And this kind of development continues to improve our understanding and the validity of diagnosis as we progress through time, okay? In the meantime, the trade off between reliability and validity still remains a concern.